Good afternoon. This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or ADA, in Charlotte, North Carolina, and I'm excited to host the second part of this educational webinar series on intravenous immunoglobulin, or IVIG. ADA's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. ADA works to promote research and create better awareness for immune disorders. So this is ADA's 6 of 12 educational webinars for 2021, and today I will be joined by Dr. Michael Rigas, PharmD, who will be discussing liquid gold and an open forum on IVIG Part 2. Dr. Rigas is the Chief Clinical Officer, co-founder, and principal at Cabo Fusion, an infusion therapy company dedicated to managing IVIG and other chronic and acute therapies nationwide. Prior to joining Cabo Fusion, Dr. Rigas was Associate Chief Innovation Officer for Pharmaceutical Care for Janssen Health System and Chief Clinical Officer for Vital Line CareSite Pharmacy Services. Dr. Rigas graduated from USC School of Pharmacy with his PharmD degree and completed his residency at UC San Francisco Hospital and Clinics in 1982. His area of expertise include antimicrobial therapy, immunoglobulin therapies, nutritional support, and many others. Dr. Rigas has worked on standardized coding for infusion billing, universal access via patient assistance plans, and managing Medicare Part D issues in front of the California Board of Pharmacy and CMS regional managers. Dr. Rigas is a member of the American Society of Hospital Pharmacists, the National Home Infusion Association, the American Academy of Neurology, and the Clinical Immunology Society. And Dr. Rigas has, over the last 20 years, managed or overseen the care of over 15,000 patients who have received over 20 million grams of IVIG. Dr. Rigas, thank you for joining us today on part 2 of this session.
Right. Thank you, Lauren. I appreciate that. I've now been able to log in and see the screen on my other computer, and I'm talking to you through my cell phone. So can you hear me okay?
Oh, yes. Yes. Let me see if I can get you up here.
If you can advance the slides.
Sure.
Yeah, I'm just dialed in. So why don't we go to slide number 13, which is where we start off with part 2. And all right.
Oh, there it is.
I think they stay right there. It was good. So good afternoon, everybody. And using the platform we're using today, we know that you're sending questions in by text, and Lauren's bringing them up as they come up. So before we start, I want to ask if there's anybody that has any questions left over from last time, if you could send those into Lauren right now. I know there were some other ones we already answered by email after the first talk, but if you want to send me in, please do so now. Let me recap where we left off. So in the first part of this talk, we basically talked about how IVIG is made, what the issues are, what diseases IVIG is FDA approved for, and the manufacturing process dynamics that affect IVIG in such an unusual way. And as we remember the specific patient outcome for this call, the objectives were, and they're on slide number 7 if you want to go backwards a minute, Lauren. So we were trying to make sure that by the time we're done here, that if you're a patient, slide number 7.
Yeah, it's wanting to stick. Right. This is not working today.
All right, well, I can read it then. All right, so basically you want patients, there they are. So if you're a patient and you need IVIG, more than likely you need it for the rest of your life. And just as in real life, if you had never bought a car before and you needed to buy a car, you would be getting advice from a lot of people, and you would be asking questions like, how much is it? What's the insurance? How fast does it go? Does it stop good? Is it safe? And you'd be aware of, whether it's a Toyota or other kind of car or some fancy car or something else, you know a lot about it. But in many cases, patients don't. They get a prescription from their doctor, they get started. So I wanted to make sure that all the patients in this call knew the impact of the FDA-approved diagnoses, which we saw last time. There's only about 15 of them. All other diagnoses, of which there could be several thousand for IVIG, are not FDA-approved. And that doesn't mean it can't be used, but it means it may be an issue with insurance. I wanted everybody to know how much it costs to the payer. and that payer is the insurance company. So obviously, everybody's hoping that their insurance company pays for some or all of their therapy, and it may be for immune deficient patient $100,000 a year to the insurance company. It may be for an autoimmune neuropathy patient, it may be $200,000 a year. So those could be big impacts. And then we want to know about the cost of therapy to the patient. That is the true out-of-pocket, how much you have to pay as your portion. And I typically use 10% of the total. So that could mean you could pay $10,000 or $20,000 a year, and that could be a problem. I also like everybody to know how big of a workload you are as an IVIG patient to your doctor. Your doctor wants to help you. Your doctor's main goal in life is to make you better. But obviously, there's a lot of work in a doctor's office that goes with managing IVIG patients, and we need to make sure you know where that puts you in the level of workload to them. And then the impact of multiple IVIG formulations on you, and that is there's about 10 different formulas available in America now, and how that can impact you. And then also the impact of manufacturer shortages and payer formularies, and inherent in this is the cost and the price and other issues. So let's move ahead, Lauren. Can we go to slide number, let's go to slide number 14 to start with. Next one.
Okay.
Okay, there it is. Okay,
Yeah, it keeps
there.
going back.
Nope.
Sorry.
Yeah, all right.
Okay, hold
We
on.
got to cut the screen.
It is very touchy.
If you just use your page up and page down function,
Yeah,
usually
that's what I
can get
was.
it to go.
There it is.
There we go. Okay. All right. So just to recap here, we talked to all those factors have led pharmacists, hospitals, and payers and patients to be very wary of IVIG. It's not a therapy to be taken lightly because of its cost and impact on everybody. And most insurance companies have developed some kind of program to minimize the use and to make the cost less to them, by either doing prior authorization or saying, you know, we think this dose is too high, or we think this is not an approved diagnosis. And so I said these programs are typically not patient-centric and are often result in unexpected responses. So if you go to the next slide, Lauren. So this is a very busy slide, but let's just break it down a little bit. And my idea here is to show that the patient is in the middle of all these different groups that are trying to optimize their own benefit. And I call it the pharmacoregulatory storm. So you can see the federal government, the state government, the drug maker, the payer, that's the insurance company, you, the patient yourself, the pharmacy industry, that is all of us, pharmacists and pharmacies, the physician, and the hospital, if you have to do in and out of the hospital, all have something to impact. So as an IVIG patient, you need to know this. You need to suspect that other people are going to be trying to get information from you, and you need to suspect that they're going to try to minimize or prevent you from getting it, and therefore, the more you know about it, the better you can be as a patient to keep getting it. Let's go to the next slide, Lauren. And I'm more than willing, if anybody wants to, during this call, bring up questions about these slides, or if you want to contact me through Lauren afterward, I'd be happy to explain any of these things in much more detail. So this is the process, the referral process. You may not realize what happens when a doctor gives you a prescription, but say you're coming from an outpatient clinic and your doctor says you need to be on IVIG, you might get a referral to my company or other companies. And when we do that, the first thing we're going to do is figure out, do you even have insurance? Are you eligible? And that typically means, did you pay your premium that month, or did you quit your job, or did you somehow become ineligible because you change jobs or change insurance companies or did something? So that's the first thing we do, is look to see, do you even have insurance? Then the next thing we look at is the benefit. And the benefit is, do you have coverage for home? Because most insurance policies have coverage for hospital and coverage for doctor's office, but most of the IV and sub-Q IV is done either in a patient's home or done in some kind of infusion center that's an outpatient. So that's the next thing we do, is look to see where you qualify to get your infusion. And not everybody has all the benefits they would need. Then the next thing is authorization. Based on your doctor's prescription and based on the drug chosen and your diagnosis, the insurance company has to decide if they're going to pay or not. And if they do decide to or not pay, to pay or not to pay, then likely they're going to give us, the pharmacy, and your doctor an authorization that's in writing that would say, we agree to pay for the IVIG for Mr. Smith at this rate for this amount of time, typically 6 or 12 months, with this diagnosis, and this is what the cost to Mr. Smith will be, and this is what we'll be paying the insurance company. So that's an authorization, and most pharmacies and doctors and patients don't want to get involved giving IVIG to somebody unless we know somebody else is going to pay, because as I said, it could be 100 or 200,000 a year. And the next thing is, after the authorization, the patient's true out-of-pocket becomes aware to us. That is, the authorization document will typically tell us how much does the patient have to pay and over what time period. And then the acronym for that is big T, little r, OOP, all big. That's the acronym for true out-of-pocket. And if the patient, let's just say Mr. Smith in my example, needed to pay $10,000, and let's just make it easy, it was $850 a month for a year, and Mr. Smith said, there's no way I can pay that, then the first thing we do is look at the patient assistance plan, the PAP, to see if the drug maker or some other 501c3, that is for nonprofit organization, or other support groups have any money available to help Mr. Smith not have to pay his $800 a month. Now, some companies like our company and others have their own assistance plan, and typically we may get, in my example, we may get back $5,000 from an organization for Mr. Smith. That still leaves, in my example, another $5,000 has to come from somewhere else. And there may be a way for the pharmacy company itself to help the patient out if they meet certain criteria, which is set forth by Medicare and other rules as to how much money you can make and what other things can happen to you before we can legally waive any part of your copay. The next thing we do then is calculate the out-of-pocket for the life of the prescription. And this is often a surprise to the patient, because I just did it easy and said $10,000 a month, a year divided by 12 months. But typically the out-of-pocket is front-loaded, and you pay more in January, February, and March, and then in April, May, and afterward it goes down. So you may be paying $2,000 a month in January, February, and March. Okay, that would be $6,000, and then the other $4,000 you'd pay by the month. So maybe you'll be paying $200 or $300 a month in December, etc. And then eventually in January it resets again. So one of the things that's important to realize is that the amount of money may be a problem, as well as the periodicity of the money that you owe. That is, it's more at the beginning of the year until you meet your deductibles, and then after that the catastrophic part kicks in, but still in January it starts all over again. So that's the life of the prescription. That can be very disrupting to patients who in April, May, in August, September, October, November, December, they may think life is good. And then when January happens and it goes back to what it used to be last January, it can be very, very stressful. So then the choice of the drug, that is, the doctor typically tells us that he or she wants IVIG or sub-Q IG. They very rarely tell us the brand of drug, and they expect the pharmacy and pharmacist to figure out, in conjunction with the payer, what is the best clinical drug for the patient to have, and then how does that jive with what the payer wants to pay for. Usually the payer has some kind of a formulary, so we try to figure out, of the available drugs, what's going to be best for the patient clinically, and then after clinical, then we consider financially to the patient, and then if that isn't one of the drugs the insurance company wants to pay for, then we have to go and get a override from them. So after the drug is chosen, then we have to figure out how much nursing does the patient need. And that is it an IV where the nurse is going to come and give every dose at home? Or is it a sub-Q where the nurse is just going to train the patient, and after that, then the nurse is going to leave and the patient will do it themselves? And then we need to communicate this plan of these updates, if there are any, to the patient and the doctor, and we need to be able to report these things and have meetings with payers and doctors to go over this if they want us to tell about how the patients are doing at the end of a month. But this is a complex referral process, and many times the patient may not be aware of the complexity, nor they may be not aware of where they are in the place of this. And then finally, I forgot, on the right-hand side, to choose the site of care. Is it going to be at home? Is it going to be a doctor's office or infusion center? Is it going to be a nursing home, or is it going to be some other place? And we have patients in all these places, but most, like 90% of our patients are at home, maybe 5 or 6% are in a doctor's office or infusion center, and a very small amount of nursing home, and very small other. Sometimes they're in assisted living, sometimes they're in a hospice and other places, but that's pretty rare. So this is very important. And if you're a patient, you just got a prescription, you may not recognize where you fit in this triage process, and therefore knowing this and knowing where you are can help you negotiate and navigate through this better. So let me see if there's any questions showing up on my monitor. Okay, no questions. All right, next slide, please, Lauren.
All right.
All right, and we already looked at the listing of those available last week, so I'm not going to go do that now. So let's go after this. Let's go to the next slide. The next slide. Now let's talk about the things you need to know if you're an IVIG patient or a sub-Q patient. What should you know? Using my example as the car. If you didn't know anything about cars and you got a car, you would want to know, is it a luxury car? Is it an economy car? How fast does it go? How safe is it? All those things. So in this case, because IVIG is a very hotly desirable commodity, you need to know some things about it so you can know what can happen to you or where you fit in. So right now, on-label means that is, if it's FDA approved and use it for one of those FDA approved diagnoses, then it's on-label. So you can see here that most of the things are not on label, and my numbers don't add up to 100% here, but you can see primary immune deficiency and CIDP, which is mostly a neuromuscular disease, they account for more than like 56% of the total, or thereabouts, 50%, with immune thrombocytic purpura being fairly rare and multifocal motor neuropathy rare. And then there's plenty of off-label uses, and you may or may not recognize, but in America, if a drug is approved by the FDA for anything, then it can be ordered and used by a doctor for any other diagnosis that he or she wants, as long as there's literature to support it. So if you're an immune deficiency patient, then you ought to know that you make up about a quarter of all the patients. Or if you're a CIDP patient, you make up about a quarter of all of them. Therefore, people, insurance companies, other people should have heard of you and know about your disease. But if you're an immune thrombocytic purpura patient or a multifocal motor neuropathy, those are very rare, and they're often, your insurance company has never heard of that, or who you talk to may not even know what it is, and therefore make a difficult time for you. So knowing your diagnosis and knowing whether it's a common or uncommon diagnosis is important, because each diagnosis has criteria the insurance company sets up before they'll agree to pay for it. And the common ones have common and easy to achieve criteria. In some cases, the uncommon ones have hard to reach criteria, or it just says we're not paying for that at all. Okay, so it's very hard. And after you've been a patient, say you've been sick for several years, you get your doctor, you get diagnosed, they try other things other than IVIG on you, and a year or two later, they finally decide they want to try IVIG. Then it's important to know what your diagnosis is and how likely that is to be easily approved, versus the fact that it may be something insurance company doesn't even think IVIG works for, and therefore it's going to be a rough go to try and get it approved. So let's move ahead. Next slide, please, Lauren.
Dr. Rigas, I just want to make a very quick comment on this slide, because one of the, and this pertains to 2021, one of the FDA approved uses for IVIG is Kawasaki's disease. And
Yes.
we have seen with COVID-19 a significant rise in Kawasaki disease due to COVID-19 infections. So I was wondering, not to go down a rabbit hole, what your thoughts were on that, because I'm guessing, that the use is going to continue to go up for on-label, not off-label. But I was just
so in the I can answer that. A good question, Lauren. Thank you. So in the non-COVID environment, there are 10 times more off-label uses than there are on-label, and probably overall maybe a third of all IVIG is used for off-label things, and only 2/3, maybe less, used for on-label. But when COVID happened, and we're going to talk in a minute about several things that COVID is going to impact the IVIG supply, and also what you're talking about, Lauren, the Kawasaki disease, the new name for that for pediatric patients is like multi-system organ failure. It has an acronym, but it's like Kawasaki disease. And Kawasaki disease is actually the first FDA-approved indication for IVIG way back in like 1960. And all the dosing that we used for IVIG was developed for Kawasaki disease way back in like whatever that was, 40 years ago, 50, 60 years ago. So right now we have seen a number of patients, and we see them in the news, children in children's hospitals getting sick. We see they're very empathetic looking. We see some have died, and much less have died recently when this first happened last year in the pandemic. They didn't really know how to treat them as well. So there's less dying now, and this new disease is very much like Kawasaki disease caused by COVID, and we've seen IVIG tick up. But the good news is that the drug that they use, IVIG, the brand they use for Kawasaki and this other multi-system failure disease in children in the hospital, is not one that's available outside of the hospital and not one that's available to adults or anybody else other than a kid in the hospital with Kawasaki or multi-system failure. And that drug is called Ascentive, and may be pronounced slightly different than that, but it's only for inpatient use in children with Kawasaki, and therefore it doesn't really affect the amount available for anybody else outside that's not one of those kids inside.
Okay.
But if you go to the next slide, the next part of your question is going to come in the next slide. So go ahead. All right. So now, and these are just to give you an idea of where you fit in the world. So let's say there's 325 million people in America, and basically we have about over 500 blood collection centers that are collecting blood, and they're turning that blood into plasma, and then that turns into IVIG, and it takes about a year from the time the plasma is collected to the time the IVIG is made and ready to be in a bottle and distributed out for patient use. And right now, we know there's a worldwide prediction of increased utilization. The most recent numbers I see just this week, about 200 million grams of IVIG used in the whole world every year, and about 100 million grams of it used in America every year. And so using that amount, the guesses are, and this is just a guess, that there's about a little bit less than 1 million patients in the United States that have a disease that could be treated with IVIG, and about half of that number have a disease that has been diagnosed and is being worked up by your doctor. And again, about half of those, about 200,000 patients, are on IVIG. And this difference between the 400,000 that have active and the 190,000 that are getting it is typically going through the process of insurance authorization, of lab tests, and everything else. So you can see what's happened here is that there's a lot of patients. We have almost a commodity, and those of you that all live in America, so we know there's a pipeline that got compromised, and we know that there's a shortage already of gasoline on the East Coast. And so just imagine, and I've used the example of a barrel of oil for IVIG, the same thing. We have a fixed number of collection points in the country, and during COVID, it was estimated that there was about a 40% decrease in the number of people that went to donate plasma because they were afraid to go into the plasma collection center to get COVID. So now we're going to have it's going to take about a year, say from summer of 2020, that's right about now, summer of 2021, just for us to see how the supply is. Now, a lot of the drug makers, they stockpile it, so they may have enough that they can take some out of their strategic reserve, so to speak, to make up for what was lost during maybe 4 or 5 months of 2020 when there were less donations than normal. So we can see here, I said about in 2019, about 75 million. The prediction is for 2021, it's going to be about 100 million grams. And we can see here, we just gave other numbers about the neurologic patients, that is CIDP, they get about 2.5 times more than immune deficient patients. So immune deficient patients going to get around 30 to 50 grams a month, and a neuromuscular patient's going to get about 100 to 150 a month in grams per month. So we know those are small numbers in reality, but in order to collect enough blood to make 150 grams of IVIG, right now you only get about 3.5 grams of IVIG per liter of blood collected. So imagine if you divide 150 by 3, you have to collect 50 liters of blood to make 50 grams of IVIG or 150 grams. So it's really a lot of work and a very rare commodity. So next slide. Yeah, sorry. So one other thing that's important is who owns the blood collection centers. That is, back to the gasoline analogy, where does our gasoline come from? It's mostly coming from oil collected in America and then refined here. But remember back 50 years ago, we had the OPEC oil crisis, and most of the oil was coming from somewhere else. And so here, the drug maker owned blood collection centers, where before they used to be all owned by the Red Cross and other nonprofit organizations. So as more get owned by the maker and less owned by individual bodies like Red Cross, the dynamics change. That is, more people may be getting paid to give blood, to get IVIG, because it's going to a drug maker-owned blood center. But also, when we used to go to Red Cross and the blood, we could know where it went and how much. And when we do it from a blood collection center that's owned by the drug maker, we know less about it and we can keep track of it less because it's a privately owned thing and not a public feature. So that means that the supply of IVIG is just like oil, is variable, and therefore we need to understand that if we're going to be a lifelong IVIG taker, then we have to realize what the risk and things that can happen are. So then recent and possible future FDA indications. So in about 2015 or so, it was FDA approved for CIDP, which is good because insurance companies can't refuse to pay for that now. But it was also thought to be approved for Alzheimer's disease, which never worked out, and right now is not FDA approved and does not work for Alzheimer's disease. So more indications get approved, the more patients want to use it and maybe are allowed to use it, and therefore that puts a strain on the demand for it. Whereas the supply part of the equation is who owns the blood collection centers and whether or not they come to give blood because they're afraid to get COVID. So bottom line is the demand is strong, but supply is ample currently, but there are bumps in the road every year. And just to show you, it happens to everybody, and there is a world famous doctor that is one of our patients, and that world famous doctor was on IVIG. I'm sorry, his wife was on IVIG, and she's a famous doctor too. And she was going to an infusion center in a hospital outpatient, and they called her and said, "We don't have enough to give you anymore, so you're going to have to find somewhere else to go." So imagine the chagrin of this doctor who spent most of his life and his wife's life educating people about IVIG, and they were told to go somewhere else because that hospital didn't have enough for them. So imagine, where you fit in. If you're not a world famous doctor, it could happen to anybody is the point. So can we go to the next slide? Go
Dr.
ahead,
Rigas, and theoretically, if we looking at this supply and demand slide here, let's just pretend that Alzheimer's is pretty common. I mean, a lot of people have it. Let's say it was approved, FDA approved to treat Alzheimer's. And you have PI patients, primary immune deficient patients, who literally that's the only drug that will keep them alive. So how would that work? Because the supply is not coming in, but the demand is going to go up astronomically if, let's say, again, Alzheimer's was FDA approved or other common condition.
Yeah, so let's go back to slide. Can you move back to slide number 15 again?
15?
That is 15, please. This one. So again, my intent here was to show the patient is basically in the bullseye here. And you can imagine if the manufacturer could get a new diagnosis and think they're going to sell more and make more money, they're going to be happy, right? And that could be a problem for the patient because it might not be enough for the patient who's got immune deficient if all of a sudden a bunch of Alzheimer's patients show up, and maybe they're going to get paid differently. Maybe they're more excited about that. And then the payer, the insurance company, is going to say, well, we don't want to pay for Alzheimer's. There's millions of them. So they're going to make it difficult. So the payer's going to put up a roadblock. The manufacturer and the federal government, the FDA, they're going to say, okay, we've now approved it for that, if that was the case. Payer's going to put a roadblock. The patient's going to say, I still need mine for my PID. And the physician may be in the middle of that. Maybe he or she's part of the research, whatever. So that was the intent of the slide, is any one of these things can impact the patient here. And if you're a patient that needs this for your whole life, you either need to know as much about this as you can, or you need to be friendly with Lauren or me or somebody, now that I'm going to be part of Lauren's organization. So if you're concerned about something, or if you think you see something in the news or something else, then you need to be able to react immediately and decide. You might have to write a letter to your congressperson. You might have to write a letter to your senator. And we go through this 3 or 4 times a year, where we are urging our patients to write letters to their legislators because something important is about to happen that's going to affect the reimbursement or something else. So did that answer your question, Lauren?
Yes, thank you. And thank you for that reminder. I'm up on the Hill every year talking about these very specific things and meeting with them.
So let's go back to slide 23 for a second, and we'll keep moving along here. So the other thing that's important is to know, if you're getting IVIG for life, you need to know where you fit in. So just the car example, you need to know if you're a Prius person that's saving gas and going slow, or if you're a hot rod person, or you're a luxury car person. So in this case, you need to know, are you getting it in a hospital outpatient setting in an AIC, or in the home or a doctor's office? Because those things could be affected by Medicare or other price things, just that side of care. So, and we know that most inpatient, if you're in the hospital, you need IVIG, it's mostly going to be for Guillain-Barré or myasthenia gravis, because those are the 2 IVIG emergencies where everything else is treatable as an outpatient. And then you think at the bottom, ground by disease state. So if your PID is in immunology and neurology here, but you can see that oncology, that is the patients that have cancer, their doctors use a lot for some cancers induce immune deficiency, and some anti-cancer drugs induce immune deficiency. And we now know there's a big group of patients that have dermatologic diseases that need IVIG, so they're coming on. So as an IVIG patient, you need to know, where do I fit in? Am I, right now, back to the car example, if everybody was buying Priuses and you had a Prius, then you probably think you're in pretty good shape. But if Prius went off the market next week and was no longer in vogue, then you might not be that popular anymore. So, and the popularity that you are as an IVIG patient, it could be that you're popular because it's a good thing to be popular, or it could be a bad thing. Maybe the insurance company says, we're spending too much money on neurology patients' IVIG doses, so we want to restrict that. So every insurance company could be having their own initiatives to try and control their own costs that could be at your expense, literally and figuratively. So let's go to the next slide, Lauren. So let's talk about drug pricing. Okay, now we said that the average cost for a PID patient is $100,000 a year. An average cost for a neuromuscular patient is about $200,000 a year. And we know that's gone up. When we started this company in 2010, the cost for IVIG was roughly $50, $60 a gram for us to buy it. And now it's more than $80 to buy it. So in 5 years, it's almost doubled. And the market strength is strong. I'm not going to talk about 340B right now. That is just for hospital and for indigent patient populations. But so you can imagine, if something's going up that much, then it's going to make a lot of people very concerned about how we're going to afford it. And here we talk about the gross profit. That is what the pharmacy company is trying to do, is make sure if I buy the drug, say for $80 a gram, I have to sell it for more than $80 a gram to stay in business. And right now, between the patient copay, which may make up 10%, I've got to collect that from the patient. Otherwise, I may be negative if I don't collect that. And whether I'm going to get help from a financial assistance plan from the drug company or from my own company, as we discussed before, those are very critical things. And so a lot of times, I have one doctor right now who's a prominent dermatologist, and he calls me all hours of the day and night from his office with patients in there saying, my patient's here, I want to, and you're on speaker, I want you to tell me if this diagnosis is approved or not for this payer, and also this is the insurance company the patient has, and what do you think the out-of-pocket's going to be, and if it's more than the patient can afford, what are you going to do to help them? So a lot of the doctors now are becoming very proactive, knowing if they don't have a pharmacist like me, my company that they trust, or some other company they trust, that the patient's going to get a prescription, the pharmacy is going to tell them they owe $10,000, and the patient's going to say no way, and then the patient's not going to get the drug, and the patient's not going to get better. And when you're the doctor, your whole goal in life is to make the patient better. Therefore, that the doctors, many of them are spending more and more time trying to optimize this now. So next slide, please, Lauren. So this is a busy slide here, but I just want to bring up the fact that the reimbursement for IVIG is very complicated. And I'll be happy if anybody wants to talk about this later or individually or anything else. I'm open to this. Lauren can arrange it if you want.
Sure.
But Medicare Part B, as in boy, it pays for sub-Q IG and some kinds of IVIG only for immune deficient patients in the home. It does not pay for neuromuscular patients in the home, and it pays for both autoimmune and neuromuscular in the doctor's office or hospital outpatient, but it pays at a rate that is known as ASP plus 6. And back to the Prius example, imagine the ASP plus 6 is less than the Prius cost. So who's going to sell a Prius if they get paid less than it costs? So the problem with Medicare Part B is it pays so low that it makes it very difficult for the pharmacy to stay in business, getting paid less than Medicare, getting paid less from Medicare than they pay to buy the drug. So it's very complicated, and with Medicare Part B, there's no pre-authorization, so you can't call them up and say, are you really going to pay for this? And one billing mistake can be catastrophic. So if you're a Medicare Part B patient, you really need to become friendly with your pharmacy so that you know what they're doing and they ask all the questions they need to ask you and you're interacting with them. So it's always better if you're a patient to make sure you talk to the reimbursement people at your pharmacy, make sure that you know that's getting paid, make sure you know if you're paying you're out of pocket or you got a waiver somehow or a patient assistance plan, that you keep track of all that stuff because it could change in a blink. I mean, what's available could change, the drug could go on shortage. It may be that you decide to change insurance because you just turned 65. That's going to have a huge impact. So these are very important concepts here. So then on to Medicare Part D as in dog, that is the part that covers just the drug. It doesn't pay for nursing. It doesn't pay for infusion. It doesn't pay for the pump or supplies. Okay, and they're paid at a different rate. Okay, which is amazing that Medicare, two different parts could pay two different rates. So AWP minus 15, back to the Prius example, that's more like the MSRP on the window sticker minus 15%. So if you get paid AWP minus 15, then the pharmacy can make enough to stay in business, where an ASP plus 6 is less than the cost of the drug typically, and therefore very difficult. So there's a lot of things here, and this one slide could be the subject of a whole day's lecture. So I don't want anybody to agonize over that. I'd be happy to answer questions either now or later, or and if Lauren wants to make comment because she's a patient and she's been in the middle of all these things herself. So I'll stop there and see if there's any comments or questions.
I have a comment, Dr. Rigas, just because I deal with these type of patients all the time, and then I have a question for you too. So my comment is, this is something I tell patients, you really have to know your plan. Whether you're on a governmental health plan also dictates if you can get patient or copay assistance, and that pertains to Medicaid, Medicare, TRICARE, any type of governmental health care. The majority of them do not offer. The manufacturer copay assistance programs aren't offered and to them, unfortunately, and that can make it quite unaffordable for many of those patients. That's just my very, very quick comment. Did you want to add anything to that, Dr. Rigas? Again,
yes, and you're exactly right. I just want to make a distinction. The reason that those assistance plans are not offered to Medicare and Medicaid patients is because there's a rule in Medicare that believes if you give a patient any kind of a break on their cost, that is considered fraud and abuse.
Mm-hmm.
And that is a big deal for Medicare. And the reason it's fraud is that they think that, like, if I did a patient and I said, okay, I'm going to waive your $10,000, and that is a Medicare patient, then that patient would go back to their doctor maybe and say, gee, this pharmacy did a great job for me, and that doctor is going to send me more business. And so the idea that you would give somebody a discount in order to get the referring person to send you more business, that is a basic human behavior over the last 100,000 years since humans have left the cave. We've been bribing people left and right, and only in the last 20 years did Medicare decide that is a fraudulent behavior. So now we have to be wary of that if we're going to give anybody a discount, they can't be a Medicare or Medicaid patient, and if we do give them a waiver, they have to meet strict criteria, we have to keep track of it. So if 5 people all show up for the same therapy, and all 5 say they can't afford their out-of-pocket, and every one of them gets treated individually. What's your income level based on the federal poverty level? What other bills do you have? Can you do a payment plan? Can you pay part of it? All those things are typically how that gets handled in order that everybody gets treated the same. Mm-hmm. So it's a very complex thing, and the problem with most patients that need IVIG is they're so overwhelmed with their diagnosis and the doctor visits and lab tests and CAT scans and whatever. When they finally get the prescription, they think they're home free. And that just, I might have said this last time, but I believe if you think of this as a circus, and remember in the circus there are flaming hoops, and the tiger has to jump through the hoops. So just imagine for an IVIG patient, there are 5 flaming hoops, and the patient has to jump through the hoops with the help of the doctor and the pharmacy. Are you eligible? Do you have the benefits? Is there going to be authorization? Can I afford out of pocket? Each one of those is a flaming hoop. If you don't make it to the flaming hoop, then you never get the drug. So this case, it's very complicated, and every patient should understand as much as they can. And if you're not good with numbers, or maybe you're older and maybe you're not feeling like you want to get in this detail, you really need to get somebody in your family or somebody like Lauren or me or somebody else to help you understand it, because this can be the difference between life and death for an immune deficient patient, and it could be the difference between, having a decent life and having a horrible life just as much than as being alive and doing well or being dead if you're getting infections. So these
that's what
Medicare,
we're here for patients and as a resource for patients. So if you ever have questions, just call or email us, and we will definitely get back to you. I did have a question after you finished that comment, Dr. Rigas.
Okay,
From
so I'm done with that.
attendee.
I'm done with that. I'm
Okay.
done with that comment. So go ahead, pop the question.
Thank you. So does the Medicare new 2021 HIT supplier fall under IG therapy for the HH billing?
So
Home healthcare.
this is a complex situation and well beyond the time we have left to discuss. But let me talk about what happens with Medicare. So years ago, there were no home infusion pharmacies, and there were retail pharmacies, and there were people that sold wheelchairs, walkers, and beds. Those would be the DME people, and there were people that did oxygen, and all those people billed Medicare somehow for the therapies they did. But when it came to home infusion and home IVIG, Medicare didn't really fit very good. And so first they made those infusion pharmacies get accredited, like by JCO and things like that. So they had to be accredited. Then after that, then they still said, we're only going to pay for Medicare Part B for immune deficient patients, not for neuromuscular patients, and all kinds of other weird things. And then they said, well, if you want to expand the number of diseases that Medicare will pay for home infusion therapy, we want to have a different kind of accreditation. That became the HIT accreditation, which we went through at our company in 2019 and some in 2020. It's just a little bit more formal, but no different than the accreditation we already had from Joint Commission or other groups that are mimic Joint Commission. So this is just another complexity for Medicare to try and cover more therapies. But right now, the HIT thing and its exact impact on IVIG and sub-QIG is, in my mind, still being worked out, because it's only started, I think, last summer. Summer of 2020 is when the HIT surveys first started to happen. And the HIT stands for Home Infusion Therapy, if you did recognize that acronym. And so I think the jury is still out on the real benefit and risk and problems and solutions that this is going to bring us.
Thank you
Okay.
for that answer.
So I'm sorry I keep giving the same sounding jaded answer, but I try to be optimistic, but Medicare and Medicaids are a problem. So now let's go to the next slide, please. All right, now let's just zoom in on Medicaid to make it more complicated. Medicaid, which in California is called Medi-Cal, for those of you living here, like me, Medicaid programs vary dramatically by state, and they typically cover a broad range of diagnoses. The reimbursement is typically good. Supplies are billed separately. So if you want to bill, say, North Carolina Medicaid, you have to have a contract with DME to bill for supplies, sometimes a contract separately to bill for nursing, and sometimes a contract separately to bill for the pharmacy. And then since I wrote this slide here, I wanted to add one more bullet that's not here, and that is that many states now have managed Medicaid. And for those of us that live in California, we know we have Molina, we have Cal Optima, we have CentCal, these things, and some are privately owned and are nonprofits like Molina, but have for-profits part of their company, other places, and some are county run, like Cal Optima is really Orange County, California, managed Medi-Cal. So here in California, and I was going to give an example, it's either North or South Carolina, is just switching from one only state Medicaid to having 4 state Medicaids now that are managed Medicaids. So if you want to do business in North Carolina, South Carolina, whatever it is, you have to get contracts of all 4 of those plus the state. You can't have a contract with a new managed care one unless you have a contract with a state to begin with. So it makes it very complicated. And then the commercial payers equally complicated because they use FDA-approved indications. They use proprietary pre-authorization criteria, like Blue Cross of California has maybe a 50-page document of which kinds of IVIG they'll pay for. And Blue Cross of New Jersey, for example, may have a 2-page one. So it varies on each one. The policies can vary from complex to basic. Consensus papers are commonly used, and many of those are years old. They typically favor home, the site of care of home, over ambulatory infusion or doctor's office, because they don't want to pay the extra fees for the doctor's office or make it easy for the doctor to diagnose the patient, prescribe the IVIG, and then bill for it and make money on their own prescription. So it's a very complex situation. So again, beyond the scope of our discussion today, and I think I'm going to end there because it looks like all the other slides that I have are, we've already talked about them somewhere, somehow so far. So let's see if there's questions right now, because I think we only have a couple minutes left. I want to give time for questions.
Sure. Does our audience have any more questions for Dr. Rigas? Okay. Well, again, please use us as a resource anytime for yourself or others that you may know. Thank you, Dr. Rigas, for being with us this afternoon and volunteering your time to educate our community in this wonderful presentation.
I
and thank you
appreciate
to
that.
our, go ahead.
So I was going to say one final comment just to wrap this all up. I think the analogy I like to say is an informed patient is a better patient.
Yes.
Okay, and that may sound logical and easy to say, but the more you know about the disease, the drug, the insurance company, the marketplace, of who else gets that drug, the better off you're going to be to meet the needs that you have for the rest of your life, possibly, to get your IVIG. And if you need to ask questions, you should never shy away from asking questions, because these complex issues I've just brought up are only likely to get more complex in the future, not less complex. So this is something that will never go away, and you need to understand it. If you're older and feel like you can't grasp these concepts, you need to find someone in your family who is younger, or get help from someone like Lauren or me to understand this so that you can be your best advocate. So good luck to everybody. And Lauren, thank you again. I hope if there's any questions that come afterward, we'll talk about them. And if anybody wants to talk one-on-one with Lauren or me, then she'll help you get us in touch.
Thank you, Dr. Rigas. One quick final note, thank you for our audience and listening to today's presentation. And please, if you don't mind, take a few moments to fill out our quick survey after the conclusion of today's webinar to help us better serve our community. Also, if you did enjoy today's presentation, please consider making a tax-deductible donation to ADA on our website at www.godoada.org. Your generosity helps us to be able to conduct educational initiatives such as today's wonderful webinar and being a resource for our patients and medical community. Don't forget our next two upcoming webinars. The next one will be on May 21st. Sjogren's syndrome. It's not just dry eyes and dry mouth with Dr. Del Santos, and also on June 23rd for Chronic Illness 101, a young adult patient perspective with University of South Carolina Honors College sophomore Jessica Goddard. This is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, and we hope you have a fantastic afternoon. Thanks so much.
Bye.